Okay, welcome back to Chapter 19, Diseases of the Eyes, Ears, Nose, and Throat. Let's get started, get in the thick of the things. We're talking about eyes, ears, nose, and throat, or EENT. Make sure that you are logged in to be able to get credit for this lecture. Okay, folks, cause very commonly, especially trauma, whether it's a burn injury, whether it's a chemical injury, some kind of toxic exposure injury, may involve disorders of the eyes, ears, nose, and throat, or EENT. Many times this happens. A significant number of these calls involve trauma. So familiarity with EENT conditions will help when assessing the patient. It also allows you to educate the patient on prevention or potential care. Patients may also need to be transported to an emergency department with access to an eye specialist or ear, nose, and throat specialist. Okay, a little anatomy and physiology. As far as the ocular motor nerve or the third cranial nerve, all of these connections of these two nerves is a connection to the brain by the two nerves. Their ocular nerve, which is the third cranial, what it does is it innervates the muscles that cause motion of the eyelids and the upper eyelids. It also carries some parasympathetic nerve fibers that cause constriction of the pupil and accommodation of the lens. Then you have the optic nerve, which is the second cranial nerve. It provides a sense of vision. This is a very good diagram showing the anatomy and physiology of the nerve itself. It shows very distinctly the different components of the nerve. This area here being talking about the anterior compartment. Okay, this is the forward compartment and what it contains, and then the posterior compartment that's filled with the vitreous humor and the different layers. Let's turn this off real quick. There we go, showing the optic nerve, the artery and the vein that supplies the blood vessels here in this area. Also the retina, the choroid, and the sclera. All right, this is also another diagram or representation showing that where your locations of the lacrimal gland, basically the external, and also the tear glands, and also the ducts where they're located. This is slide 5 of 102. All right, so patient assessment. These can be very unique and very trying at times with patient assessment. We need to ensure, obviously, our scene safety, keeping your patient calm, form a general impression, assess the airway, note environmental clues that may be causing problems for this patient and the patient's eyes. Note that the approximate age and sex of the patient, note the patient's degree of distress. Assess the airway and breathing, rule out live threats. Do not be distracted by swollen, irritated eyes, or that will make you miss your priorities. Early transport may improve outcomes. Cover both eyes to limit damage to the affected eye through the sympathetic movement. Consider pain management. Cardiac monitoring is recommended. Ocular pressure can stimulate the vagus nerve, therefore causing bradycardia. Eye drops, medication can cause side effects such as low or high blood pressure. So you need to make sure that this patient is taking either one of those, that we're aware of that and take into consideration how it affects the overall systemic system. All right, other things we need to obtain our chief complaint history. Symptoms that may indicate serious ocular condition include the following: visual loss that doesn't improve blinking, it doesn't improve with blinking, double vision, severe pain, and any foreign body sensation. Assess for pain, tenderness, swelling, any abnormal movement, any sensation changes within the eye itself, any circulatory changes, deformities, visual changes, and then the airway compromise. And we need to really look at the structures themselves. You're assessing the following visible ocular structures: the orbital rim, looking for ecchymosis, swelling, lacerations, any tenderness. Also, you take a look at the eyelids. Same thing: ecchymosis, swelling, laceration, any other abnormalities. Take a real close look at the cornea and make sure that there's no foreign bodies in there. All right, so other things we're looking at: conjunctivae, the redness, any pus inflammation, the globes themselves. What is the general size of the globes? Do the globes appear to be swollen or larger? Was one larger than the other side? Is there any redness or pigmentation in the globes themselves and any laceration? Then the eye surface, growth, discoloration, any differences from left to right. And then the pupils. We want to know shape, size, equality, and the reactions to light. We're looking at the eyes itself and assessing for ocular function. Perform these following tests. At minimum, a visual acuity test. And then, of course, that visual acuity test is the ability to see large and small letters. Test each eye separately. Document the results. Also look at their peripheral vision. That's testing the ability to recognize an object entering the extremes of the visual field. And then ocular motility. That's checking the ability to move the eyes in all directions. I also want to see if there's any check for paralysis of gaze or discoordination between the movements of two eyes. We call that a disconjugate gaze. All right, so the patient may experience some adverse effects if he or she uses more than one eye medication, uses too much medication. Ask the patient how he or she administers any medication he or she has used. Generally recommended to wait about 5 minutes between the first and the second drop. Eye drops and lubricants can be applied by the following methods. Gently squeezing. I mean, this is generally they're used for conjunctivitis, dry, red, or itchy eyes, eye pain, glaucoma, eye surgery, herpes simplex, corneal abrasions. Lubrication purely for tear production or lack thereof. Eye drops and lubricants, we're going to apply them by gently squeezing into the lower lid to make a little pouch, applying the medication into the lower lid, having the patient close the eyes and roll them downward, then applying gentle pressure to the corner of the eyes to prevent drainage of the medication from the eye itself. Irrigation may be necessary. We always use sterile water. It's much more preference. Irrigation, in case there's a chemical burn or a thermal burn, that kind of stuff. We're going to use sterile water or isotonic saline is fine. Flush from the corner, inside corner of to the outside. Very good stuff. That way it, will run down, the side of the face and completely get away from the skin. Flush liquid from that inside, copious amounts for at least 10 to 20 minutes. All eye injuries should be seen at the emergency department. Sometimes these eye injuries can be irreversible. Contact lenses, the only indications for removing a contact lens in the pre-hospital setting is a chemical burn of the eye. 3 types of contact lenses. You have hard, rigid gas permeable, and then soft, which are hydrophilic. To remove hard lenses, use a small suction cup, moisten the end with saline, and then stick it right on there and pull it out. To remove soft lenses, place 1 or 2 drops of saline in the eye, gently pinch the lens between your finger and lift it right off the eye. Suspect, if they have eye prosthesis, you could suspect if the eye does not respond to light, does not move in concert with the opposite eye, or does not appear quite the same as the opposite eye. They may have a prosthesis in there. Plus, you ask the patient, do you have a fake eye? So I was like, hey, I got a fake eye. Yeah. So yeah. Okay, use of the ophthalmoscope. This is rarely used by paramedics. Okay, it's just practitioners in hospital or physician's office may use the ophthalmoscope, but it's rarely used by us. It consists of a concave mirror and a battery-powered light, usually contained in the device's handle, a rotating selection of lenses and adjustable depth and magnification. It creates an effective evaluation of the eye with this device. It requires the following: dilation of the patient's pupil with the medication. You need to have significant diagnostic expertise. And as far as doing this, we'll practice using skill drill 19-1. Conjunctivitis. Oh man, this picture kills me every time I see it. It makes my eyes water. Conjunctivitis. The pathophysiology of this sucker is it's the following. It's a pink eye is what we normally call it. It's the layman's term. The conjunctiva becomes inflamed and red. Most often it starts in one eye and spreads to the other eye. Most often caused by bacteria, viruses, allergies, chemicals, or foreign bodies. Viral conjunctivitis is often associated with an upper respiratory virus. Bacterial conjunctivitis is caused by a bacterial infection. Viral and bacterial forms are highly contagious. Allergic conjunctivitis is caused by a trigger or irritating allergen such as pollen. Chlorine in swimming pools can also cause a problem, and also air pollution are potential causes of chemical conjunctivitis. If conjunctivitis is due to a foreign body, the eye will begin to produce tears in an attempt to flush out the object. Okay, assessment and management. Well, we're going to perform our general assessments. General assessment of the patient's vision. Viral conjunctivitis normally resolves on its own. Bacterial conjunctivitis requires a topical antibiotic, and severe allergic conjunctivitis may need non-steroidal anti-inflammatory drugs, NSAIDs, antihistamines, and a topical steroid eye drop. Okay, so inflammation of the eyelid, both clarazone and hordeolum. Clarazone, okay. Clarazone is a protective film of oil glands and oil ducts across the eye. Chalazone, very specifically, is small swollen bumps or pustules of the external eyelid are formed. Right here, a lot of people say these are styes, sty in the eye, that kind of thing. It's formed by a blockage and swelling of the oil gland. The hordeolum is an infection of the oil gland itself that produces a red tender bump in the eyelid or in the lid margin. These are commonly known as styes. This is more like an internal sty. This is more of an external sty here. Yeah. Eventually these will come to a surface and you'll be able to relieve them. Hot water compresses or hot compresses usually help a whole lot these particular issues. So although a thorough assessment and transport, the patient will usually be asked to apply warm compresses for about 5 to 10 minutes several times a day. Topical or oral antibiotics may be used as prescribed. Okay, glaucoma. It's a group of conditions that lead to an increased ocular pressure. It's one of the leading causes of blindness. Aqueous humor is the fluid that's on the inside of your eyeball. It's a clear watery fluid. It fills the eye, gives the eye its shape, and it's within the anterior chamber. It maintains intraocular pressure and provides nutrients to the inner surface of the eye and helps to bend light. It circulates through the pupil and drains into the venous system by the canal of Schlemm. Several types of glaucoma. There's open angle glaucoma. That's where the aqueous fluid drains too slowly and pressure builds up within the eye and damages the optic nerve. It is the most common type. The most common type is a normal tension glaucoma. It can cause vision changes with no increases in intraocular pressure. And then narrow angle glaucoma, also called angular closure glaucoma, it's where the aqueous fluid does not drain properly due to narrowing of the drainage channel. Pressure builds up in the posterior chamber of the eye, which pushes the lens forward. The lens then pushes the iris into the drainage canal, completely blocking it. Secondary glaucoma is the result of the conditions that damage the drainage channel in the eye. Such can be caused by diabetes, eye injuries, leukemia, sickle cell anemia, some types of arthritis, cataracts, increases with age. Usually these are all treated with eye drops to reduce ocular pressures. So assessment management. Well, there's not a whole lot we can do. Patients' complaints may involve loss of field of vision, which is specifically peripheral vision. Patients who have an acute attack of narrow angle glaucoma may report severe eye pain, headache, photophobia, nausea and vomiting, blurred vision. They also may see halos around lights. The cornea may look cloudy, and pupils often have irregular margins and can be fixed in a mid position and dilated. Also, you have acute narrow angle glaucoma, which is a medical emergency. We need to rule out trauma or physical injury immediately and perform a general eye assessment. All right, so central retinal artery occlusion. It's where the blood supply to the retina becomes blocked. Henceforth, the word occlusion. So, about this particular problem, the blood supply to the retina becomes blocked and because of a clot or an embolus of some sorts in the central retinal artery or one of its branches. Some of the possible causes: embolus from the carotid artery, valvular heart disease, drug abuse, some kind of fat emboli, some arterial spasms, and also oral contraceptive use. It may cause partial blindness, which may be temporary or even permanent. Our assessment and management is pretty easy. Sudden painless loss of one vision in one eye. You may see vision loss in the central retinal vein. The occlusions progress over about 30 to 120 minutes. Field treatment-wise, not a whole lot we can do about that other than provide support and transport to the hospital in the most comfortable position as possible. Iritis, otherwise inflammation of the iris. Ouch. Oh, I hate these. Eyeballs or my eyes are my nemesis, man. My eyes start to water as soon as I see this stuff. So iritis is the inflammation of the iris. It's also called anterior uveitis. It's the third leading preventable cause of blindness. It can be acute or chronic. Acute is caused by trauma or irritants and usually affects only one eye. Chronic causes include autoimmune diseases, differential types of arthritis, irritable bowel disease, Crohn's disease. Infectious causes include Lyme disease, tuberculosis, and sexually transmitted diseases. Right, so assessment and management. Iritis presents as a red area surrounding the iris, cloudy vision, or an unusually shaped pupil. Focus on history. Acute iritis usually responds well to topical corticosteroids as long as the cause is not fungal, viral, or bacterial. 90 different pathogens or autoimmune processes can cause chronic or recurrent iritis. Patients should be referred to a specialist. Iritis can result in permanent disability if left untreated. Papilledema, this is swelling or inflammation of the optic nerve. Some of the symptoms include headaches, nausea with possible vomiting, temporary vision loss, or narrowing vision fields. A graying in the field of vision itself is one of the things that patients complain about the most. It's temporary though. All right, so it can be caused by and other causes. All of these are on slide number 30. Abscesses, tumor, inner infections, lung infections, and then other causes, meningitis, fever, hypertensive crisis, chronic blood pressure issues, and Guillain-Barré syndrome. Assessment management, pre-hospital management, just treat the symptoms. Transport them as soon as possible, especially with the eye specialist, assessing ABCs and life threats, and administering analgesic or a mild sedative as needed. All right, so cellulitis of the orbit. Preorbital cellulitis, it's common caused by Staphylococcus or Streptococcus bacterial infections. Periorbital cellulitis is where it's more prevalent in children than adults. It's also known as preseptal cellulitis or eyelid cellulitis. Presents as painful, red, swollen eyelid. You also have fever and a redness of the part of the white of the eyes. Predisposed risk factors can include patients, insect bites, upper respiratory disorders, and also trauma. Then you have orbital cellulitis. This is an infection within the eye socket itself. Consider this as a medical emergency. The goal of treatment is to avoid the formation of an abscess. Some of the predisposed risk factors: sinusitis, tooth infections, ear infections, trauma, and also sinus infections. Assessment management, treatment includes antibiotics. Pre-hospital management includes ruling any life threats, obtaining a thorough history, and then transporting to the appropriate site for care. Corneal abrasions, it's the most common type of eye injury, very much so, seen in the emergency department. It's caused by direct trauma, foreign bodies, contact lenses, or exposure to ultraviolet radiation. Ulcer development without prompt treatment is what's going to happen. This can cause blindness if untreated, so you need to make sure that this patient gets to the hospital for treatment. Assessment symptoms include all the following, just what you see here, some pain, redness, tearing, feeling something in the eye, blurred vision, photophobia, and headaches. Management, rule out life threats, take a thorough history, and transport promptly. The ears, primary structures for hearing and balance. Disorders can injuries can leave a person unable to communicate, react, and maintain equilibrium. This is a good representation. This is a picture that's on slide 38. The ear is divided into three anatomic parts. You have the auricle or the pinna. The external ear is all part of that. It has the external auditory canal and the pinna. Middle ear to include the tympanic membrane. The malleus, the incus, and the stapes are the small bones. We talked about that today. And remember, the grouping of those bones is called ossicles. You also have the semicircular canal, the oval window, vestibular nerve, that's all in the inner ear, cochlear nerve, the cochlea, the vegetables, and not vegetables, vestibules. We have vestibules in our ear, not vegetables, the round window, and the eustachian auditory tube. This tube is very, very important. It's what drains the pressure, and it's allowed to move pressure back and forth. So, okay. Sound waves travel through the ear and the external structures from the nerve impulses that travel to the brain via the auditory nerve. The brain converts these impulses or waves of impulses, transverse or converts them into sound, so you can tell what it is that you're listening to. But it comes in as waves and pulses. All right, patient assessment. Obviously observe scene for hazards, assess patient age, environmental condition, degrees of distress, and do they have a hearing aid? Ensure ABCs, manage life threats, take a complete history, observe the ears for any drainage, any excess carmine, the wax buildup on the inside, any inflammation, and any swelling. Have the patient rate his or her pain, ask about changes in hearing, if they have any tinnitus, which is ringing in the ears, or any dizziness. Inspect for any wounds, swelling, drainage, or any battle signs in the mastoid processes. All right, so use to visualize abnormality of the external canal and tympanic membrane. This is our otoscope. Very easy to use, not a big deal. All right, so impacted carmine, this is the yellow oily substance found in the ear canal, what most people call them, wax, earwax. This stuff helps prevent dirt and water from entering the middle ear canal and may protect the ear from bacteria or fungus. It may present as a wet, which is a sticky brown color, dry, which is more like a grayish flaky color itself. It can become impacted and cause pressure against the eardrum. Risk factors include abnormal ileal canal shape, diseases that cause increased carmine, and improper use of cotton swabs. My pediatrician used to always tell me that nothing goes in your ear except for your elbow. I still can't get it in there, but oh well, I'll keep trying. All right, so assessment and management. Symptoms may include pressure or fullness within the ears themselves, maybe even ringing in the ears, loss of hearing, pain or itching. Pre-hospital treatment includes a thorough history and a visual inspection of the ear. Labyrinthitis. This is a feeling of vertigo or loss of balance. Okay, most commonly recognizes that problem after an ear infection or upper air or respiratory infection has occurred. Its effects on the nerves in the inner ear with a loss of balance from irritation and swelling of the inner ear. Other symptoms include ringing of the ears, dizziness, loss of hearing, nausea, and vomiting. Assessment management, pre-hospital treatment is directed at reducing nausea and vomiting, so maybe some phenergan or Zofran, either one. Transport the patient in a position of comfort. Serious disorders will need to be ruled out by a CT scan and or an MRI. Okay, Meniere's disease. Meniere's disease is an interesting little booger. It's a chronic condition of the inner ear characterized by dizziness described as spinning vertigo. The room is spinning, and I haven't had a single drop of alcohol. Woohoo! Low frequency hearing loss, also tinnitus, and feeling of fullness in the affected ear. There should be overproduction and also defective absorption of the endolymphatic fluid, which increases the volume and pressure within the labyrinth of the inner ear. Distension is the end result of this. The distension, ultimately will rupture and causes a mixing of the endolymph and the perilymph fluids. This mixture disrupts the balance of the fluid and the electrolytes, within the labyrinth and damages the vestibular and cochlear hair cells. Attacks of less than 2 hours in the early stages gives you an altered balance up to 2 days. As the disease progresses, symptoms last for hours to days. Permanent tendinitis, moderate to severe hearing loss, and chronic unsteadiness may result. Assessment management pre-hospital care includes an antiemetic because it's going to be very nauseated, vomiting. Physician may also treat this with diuretics and also an antiemetic. Otitis externa and media. It's an infection resulting from bacterial growth in the ear canal. Otitis externa and otitis media. Otitis externa meaning on the outside of the ear, from the opening of the ear to all the way out to the edges of the earlobes. Otitis media being on the inside, it's more common in children than in adults. Assessment and management signs and symptoms may include edema and arrhythmia, diminished hearing acuity, inflamed and bulging tympanic membranes. Pre-hospital treatment includes relieving unbearable symptoms such as the pain, gives some pain relief. Okay, so the nose, its injury, it's susceptible to injury, obviously due to its location. It's right there in the middle of your face. Nose acts as a filter, humidifier, and a heater for the air that enters the body. Allergens, particles, and chemicals can cause inflammation, infection, and injury. Complications from nasal disorders are very, very common. The inside of the nose is extremely vascular. It's an excellent route for some medications, so keep that in mind. Smelling disorders include anosmia, which is a total loss of sense of smell, diasomia, which is a distorted sense of smell, hypersomnia, which is an increased sensitivity to smell, hyposomia, which is a decreased sense of smell, and then presbyosmia, which is a loss of smell from normal aging. All right, so a little bit of anatomy. One of two primary entry points for oxygen is our nasal passages. It warms and humidified, like we talked about. There's the septum, the frontal sinus. Also talking about the turbinates. You have your superior turbinate, your middle turbinate, and your inferior turbinate. That's the makeups of the internal nasal cavity. Some other stuff, contains bony structures all throughout your frontal, ethmoid, and sphenoid. Those are the connective tissues, the sinuses that are behind those connective tissues. As far as patient assessment, look for environmental clues and scene safety, assess airway and breathing, determine the level of distress for the patient. Nasal cavities are definitely prone to bleeding. A lot of these patients know that they have a bleeding problem, especially if they may have some history of anemia or maybe sickle cell, those kind of things. So keep that in mind. Hopefully they don't have hemophilia. If they have hemophilia, you may have a true emergency on your hands. Do not insert a nasopharyngeal airway or attempt nasotracheal intubation with suspected nasal fractures, cerebral spinal fluid, or blood leakage from the nose. Inquire about the patient's history of their nose condition. Good stuff. Epistaxis, a nosebleed. Causes usually digital trauma, some dryness, or hypertension. We have anterior and posterior epistatics. Anterior bleed fairly slowly. They're self-limiting and resolve quickly. Posterior are much more severe. They often cause blood to drain out into the throat, causing a lot of nausea and vomiting. Assessment and management, try to eliminate blood loss. Place a non-trauma patient in a sitting position and pinch the nose together, as you see here in this particular diagram or photo. And then you can also provide direct the patient not to sniff or blow, but you can provide for them to press a rolled gauze 4x4 up under the nose, under the bridge of the nose like that at the maxillary level. We usually tape one in place and it should catch everything and eventually clot. Foreign body, most likely be seen in pediatric patients, whether it's in their nose, whether it's in their ear, whether it's in their mouth, in their throat, that kind of thing. Specifically with the nose, pressure in the nasal passages can cause tissue necrosis, inflammation, and also swelling. Inflammation can cause tissue ulcerization and epistaxis. Assessment and management determines the condition is life-threatening. Any persistent foul-smelling purulent discharge should lead to a suspicion. Transport these patients in a position of comfort. Rhinitis is an inflammation in the nasal cavity. Could be caused by any of these, bacterial infection, viral infection, Most commonly we see from allergens in the air. Assessment, signs and symptoms may include nasal congestion, sneezing, itchy, runny eyes, post-nasal drip. Put them in a semi-Fowler's position, maintain their airway. Sinusitis, it's sinus inflammation. It's drainage from the sinuses that becomes disrupted. It causes a variety of symptoms. It affects 29.3 million adult Americans per year. Wow, that's a big number. Assessment, management, condition may be chronic, acute, or recurrent. Treating the respiratory compromise is the main thing in transport. Treatment is aimed at reducing inflammation and draining sinuses. The throat. Disorders of the pharynx and larynx may include inflammation, infections, or abnormal growths. Throat infections are common in children. Throat problems can also be exacerbated by swallowing problems. Different forms of dysphagia, which is relative to types of swallowing disorders. Specific disorders that can cause problems include vocal cord polyps or nodules, contact ulcers, vocal cord paralysis, laryngeal seals, laryngeal papillomas, cancer, and also subsequent throat infections. Esophageal disorders can affect the throat as well. Esophageal reflux, the valve only partially closes or opens too much. These symptoms following this particular problem, patient complains of burning sensation in the chest, indigestion, and sometimes even a change in voice tone. All right, so your anatomy and physiology, obviously here's the mouth. It looks like Steven Tyler's mouth. It's huge. Oh my God. And then the structure of the tooth, the different breakdown of the tooth, all the different teeth, the molars, premolars, canine, and incisors. Mouth, a lot of nerves in there. Hypoglossal, the glossopharyngeal, trigeminal, and also the facial nerves. That all represent a certain job within the head itself. The neck, anterior portion, includes the thyroid and cricocartilage, trachea, and also the muscle nerves. Major blood vessels, internal and external carotid arteries, and the internal and external jugular veins. Here's a buildup of the neck, gives you the full structure, also shows you how the blood returns and the different names of those vessels. The retromandibular vein, the internal jugular vein, external jugular vein, internal jugular vein, subclavian, and the right brachiocephalic. So you need to know these. It's good anatomical terms. Good, nice review. All right, so patient assessment for the throat. Swallowing abnormalities require position and also to allow for drainage. Lateral recumbent or recovery position is the best. Assessment should be considered if epiglottis, there are symptoms of sore throat, drooling, or forward hanging head, or a tripoding kind of position. Okay, dentalgia and dental abscesses. Ouch. This is the dental abscess here. Rather large, painful, needs to be relieved, that kind of thing. There's not a whole lot we do in the field, but dental abscesses occur when bacterial growth spreads directly from a cavity into the gums, facial tissue, bones, and or neck. It may even have to be drained surgically or treated with antibiotics. Assessment management. Infection may become systemic, it may follow throughout the entire body, so it may have to be looking at, antibiotics early. If an abscess is in the throat, neck, or under the tongue, it can affect the patient's ability to breathe, so keep mindful of the airway. Pre-hospital treatment is aimed at relieving whatever symptoms they may have. Diseases of the oral soft tissue, it can be the root causes of other health problems. They include cold sores, canker sores, thrush, leukoplakia, gingivitis, and bad breath. Halitosis, bad breath. Remember that. I may put that on a test. All right, assessment management, rule out urticaria and allergic reactions. Management here, wash your mouth out with some scope. No. Yeah, that'll get rid of the halitosis, right? Nah, just simple, basic care. Just use your smarts there. Oral candiditis or thrush, ugh, that's what it looks like. Eee, this is yucky. Ugh. It is Candida albicans. It accumulates in the lining of the mouth. The patient will have very creamy white lesions all on the tongue. That's disgusting. Assessment management is most likely to be found in babies. We don't find them in adults. Or patients with compromised immune systems, patients who wear dentures, and patients who use inhaled corticosteroids. All right, assessment management continues. The additional symptoms may include crackling and redness of the corners of the mouth, cottony feeling mouth, and sensation of food stuck in the throat. Patients at increased risk include those with HIV, cancer, diabetes, and also vaginal yeast infections. Treat these with higher priorities and make the patient comfortable. Ludwig angina. Ludwig angina is a form of cellulitis caused by a bacteria from an infected tooth, root, or mouth injury. Physical exam may show redness and swelling in the neck under the chin. Also, assessment and management on this is that they may have difficulty in breathing and swallowing because of the size of their tongue, neck pain and swelling, fever, drooling, altered speech sounds. Pre-hospital treatment requires aggressive management of the airway. Epiglottitis is inflammation of the epiglottis. It blocks the trachea and obstructs the airway. Often it's a result of Haemophilus influenzae. It's a type B type of virus. Assessment management, here's your symptoms, signs. You need to make sure to identify these and manage them appropriately. So management, minimize scene time, do not agitate the patient, do not attempt to look in the mouth, and alert the receiving personnel that you have potential epiglottitis that could turn into tracheolaryngeal spasms. Laryngitis, it's a swelling and inflammation of the larynx. These are the causes: overuse, pneumonia, irritants and chemicals, bronchitis, and allergies. Assessment management, you may find a patient with fever, hoarseness, swollen lymph nodes and glands. Consider a fracture if you have this and there's no fever, there's no signs or no reason for this. Consider a fracture of the hyoid bone if you have swelling and fever and hoarseness and swelling in the lymph node areas. Have the patient follow up with a physician, bottom line. Tracheitis, it's a bacterial infection of the trachea. This is usually caused by Staphylococcus aureus. Frequently occurs in children following an upper respiratory infection. Trachea is easily blocked by swelling, and ultimately it could be life-threatening. Assessment management, it's got a croup-like cough, so listen to it. There may be difficulty breathing in a high fever, so let's make sure that we assess and manage the airway very, very closely. Signs, tripoding position, and also intercostal retraction. Pre-hospital care supported 100% oxygen, vital signs. Be prepared to do a very difficult intubation if that airway closes off. Tonsillitis. Oh, look at those inflamed puppies. There's your tonsil right there. There's your tonsil right there. There's the back of the throat. Oh, this is disgusting. And that is the uvula hanging up in there. Uvula. Swelling, inflammation of the tonsils. It's usually caused by a viral infection. Management, those are your symptoms, signs. Management is just making sure to maintain the airway, keep them in a good, nice sitting position, let the drool flow, put them on oxygen if they're dropping below 94%. Pharyngitis, this is a very good representation of a very irritated and angry pharynx. It's inflammation thereof. It's often due to a rapid onset of a sore throat. It's really no discomfort or pain with swallowing. It's just kind of difficult. Things don't feel right. Symptoms may include fever, headache, pharyngeal arrhythmia, purulent, patchy yellow, gray, or white exudate, and then ulcers on the soft palate. Follow up with the emergency department, get prompt treatment for this. Okay, paratonsillar abscesses. Oof, man, these are huge, very huge. This is an emergency. This is from a complication of tonsillitis. It's a very big collection of infected material in the tonsils. One or both tonsils are effective. Symptoms can include the following: tender glands of the jaw and throat, inability to swallow, facial swelling, those kind of things. Treatment involves antibiotics and draining the abscesses. So treatment may include also a tonsillectomy, prompt transport to the hospital, very much so. Different mandibular joint disorders. Their causes include arthritis, damage to the joint cartilage, jaw injury, muscle fatigue. These are usually caused from grinding and clenching of the teeth. All right, this is the last slide. Just continue on. Assessment management of TMJ. Symptoms may include headache, jaw pain, difficulty chewing, and even locking of the joint. These are managed primarily with physicians and also the dentist. All right, so that's the end of this video. Thank you very much for joining us for ear, nose,